So the subject, the subject of the talk is, of course, hepatorenal syndrome. But honestly, I want you to start thinking on these particular patients as AKI in cirrhosis without putting a name. Because regardless of the etiology, AKI in cirrhosis is extremely, extremely difficult, very challenging. Patients are often very, very sick, and is really the job of the internist who's gonna be admitting these patients to start and steering the treatment in a way that can find any sort of benefit from them. But I can tell you, more often than not, you see how challenging the management of these patients can be, because they're a really sick patient population. And I hope I can hopefully stimulate some minds here to start looking at this patient population who really has a very difficult chance. So the outline of the talk is very, very simple. We're going to briefly discuss some of the background on the pathophysiology of HRS. So I chose HRS even though I'm telling you to start thinking in terms of AKI and cirrhosis, but HRS is such a different form of AKI within cirrhosis that deserves special recognition. We're going to discuss the pathophysiology, the diagnostic criteria as we know it, and some aspects regarding the management. And finally, if I have time, I'll show you guys some of the research that we have been doing in this field. So let's start by saying AKI is very common in patients with decompensated cirrhosis, 50% in some case series, and it's associated with high mortality. To give you an example, you can see this graph of a case series of patients with decompensated cirrhosis that were admitted to hospital, and we divided the etiology of their AKI by the three most common forms, which are, perirenal azotemia, you can see that in blue, HRS, and ATN. And this is probably the first point that I want to make here. Even though we start to think on HRS as the most complicated form of AKI in these patients, truly any form of AKI can actually have devastating consequences in a patient with liver cirrhosis. So as you can see here, you start noticing how the mortality is elevated in both ATN, acute tubular necrosis, and HRS. And this is going to be a theme that we're going to be coming back going forward, because the management of both entities is dramatically different. Now, what are the triggers of decompensation in these patients that will lead to AKI? So we have infection, such as spontaneous bacterial peritonitis, volume depletion. More often than not, these patients will require large volume paracentesis, and oftentimes they'll come decompensated a couple of days after they went to their outpatient clinic, got a TAP, 4 liters were removed, and then a couple of days later they come feeling really bad and with a creatinine of 3 after they had a normal creatinine. Some of the other triggers, I don't want you to forget about glomerulonephritis. So each patient that comes to the hospital with AKI, they also have the same kidney diseases as any other patient with osteoporosis. So you should always keep in mind that any glomerulonephritis is also fair game. Alcohol hepatitis can also be a trigger, and we'll discuss this in a little bit as well. Medications, as you know very well, NSAIDs and nephrotoxic antibiotics, and probably under-recognized abdominal compartment syndrome. So how many times are we really measuring intrabladder pressure in these patients who come with really tense ascites? And I'll tell you, in some of the preliminary data that we have, we've been looking back in our records, and we are noticing that occasionally some of these patients might actually have some improvement after you decompress the intra-abdominal compartment after a paracentesis. So you got to start thinking whether or not it might be worth recognizing this etiology that, in my opinion, goes sometimes underappreciated. So we're gonna go forward. Now, this is a slide from a very old case report of a patient who had HRS. And I don't know how they got away with it, but they injected IV contrast. And as you can see in panel A, the patient with HRS had a severe vascular contraction as compared to a patient who did not have HRS. And I just really love the pathophysiology of this disorder, because I like to think as HRS as the most extreme form of prerenal AKI. So it's so extreme that it will never respond to IV fluids. And that should give you a clue when you're facing these patients. So let's start talking about the pathophysiology of HRS. And this is probably my favorite slide of the whole deck. So we're gonna start talking about 4 interrelated pathways that have been implicated in the pathophysiology of HRS. And here we can start seeing how the disorder is basically related to the vasculature. It's a disease of the vasculature that starts within the liver. So 4 factors, in my opinion, are the ones who are implicated in the pathophysiology. First is the peripheral arterial vasodilation, which causes an hyperdynamic circulation that leads to renal vasoconstriction. Then you have the stimulation of the sympathetic nervous system that would also lead to renal vasoconstriction. Cardiac dysfunction can be alcoholic cardiomyopathy, can be ongoing tachycardia, will also lead to this hyperdynamic state in which the vasculature is altered. And finally, I'm going to explain the potential roles of some cytokines who have been in active research. So here I'm highlighting some of the aspects that I consider really important in the pathophysiology. So peripheral arterial vasodilation. So in the setting of liver dysfunction, everything starts with the liver that is cirrhotic, that is scarred, and that has portal hypertension. So portal hypertension is the requirement for a patient to have hepatorenal syndrome. No patient without portal hypertension that presents with AKI will have HRS. So that's something I want to give you as a clinical pearl when you start thinking about these patients. So because of the decrease in the elasticity of the liver, there's going to be a splenic vasodilation. So that's where all the ascites is coming from. So the splenic vasculature is going to dilate, and it's going to have this capillary leak type of physiology. And that's going to decrease your effective arterial blood volume. You often see that these patients can sequester 8-10 liters of fluid really easily. So you can imagine how your baroreceptors are going to be unloaded, and that essentially activates the sympathetic nervous system. But the same token, the low effective arterial blood volume will lead to a non-osmotic release of AVP or vasopressin, which is also a very potent vasoconstrictor. And within the renal vessels, the renin angiotensin aldosterone system is going to also start to kick in. So these 3 interrelated pathways are also going to lead to an extreme renal vasoconstriction. Now, there is also a recognized form of sympathetic nervous system that is essentially confined to the renal system. And it's essentially because of the hyperdynamic circulation that it has been described that the renal sympathetic nervous system also plays an important role, further worsening the renal vasoconstriction. Now, and here's when we start thinking, so if this disease is causing a lot of vasoconstriction, why do we even use vasoconstrictors for the management of this for this disorder? Because specifically for the splenic vasodilation. So if we are able to find direct splenic vasoconstrictor, that's going to be the key for the management of these patients. Next, the other factor that goes into the pathophysiology of HRS is the cardiac dysfunction. So cardiac dysfunction, where it comes from. So really don't know exactly what are the pathophysiology aspects that lead to the cardiac dysfunction, but some researchers advocate that in the case of alcoholic cirrhosis, you have alcoholic cardiomyopathy that will lead to increase of atrial natriuretic peptide, despite having activation of the viral receptor because of low effective arterial circulation. And guess what? This natriuretic peptide is also going to exacerbate the renal vasoconstriction. Next is the cytokine activation. So I'm going back here. So cytokine activation is also one of the most exciting areas of research currently. And there are several substances that have been studied. TNF-alpha, endothelin, endotoxin, glucagon, but probably the most studied one is nitric oxide. So there is a great deal of expression of nitric oxide synthase in the splenic vasculature. And really, the hypothesis is that nitric oxide can also be activated because more often than not, these patients suffer from bacterial translocation. And it's been thought that this milieu of endotoxin and arterial vasodilation can also be driven by nitrous oxide. There were studies a long time ago in which some of these patients were given norfloxacin, and in a number of patients given norfloxacin were able to prevent the development of HRS. And some researchers claim that it's basically related to the decrease in release of nitrous oxide. This still is a controversy because nobody knows yet if the extent to which this particular substance is really causing a role. But the problem is that despite elevated levels of nitrous oxide, there has been pharmacologic treatments in experiments in animals that haven't been able to really reverse AKI in cirrhosis. So that's still in the works. And finally, the features that we typically see in clinic when our patients present to us will go into the functional AKI that these patients have with renal sodium retention. So remember, I told you this is the most extreme form of perirenal AKI. So low sodium in the urine chemistry is going to be very, very key, very easy to get, very quick to obtain. It can give you a lot of information. There's going to be a decrease in solid-free water excretion that would also lead to hyponatremia and basically a decrease in GFR. And these are the things that you start looking into your patients when they come from clinic with a history of not feeling well, they have AKI, they have cirrhosis, they have ascites, and you start seeing these features more often than not, you'll probably be in front of someone who's suffering from HRS. Now, the way I like to think about this disease is a spectrum. So you have patients in which, despite having liver cirrhosis, despite having ascites, they are still able to maintain a normal circulation. But still, you know that these patients will probably live in what we call hepatorenal physiology, in which a decompensation or in which a trigger will move the needle in some direction versus the other and will put the patient into hepatorenal syndrome. So I see them as a spectrum, that even though the patient will have normal lab parameters, the clinical presentation is going to be such as someone with compensated liver disease, but start thinking that these patients actually live in this particular continuum, and it can go either way depending on any triggers or not. So speaking of triggers, so there are the precipitating factors that are already well described in the literature. Some of those are infection, and this can be SVP, but certainly can be any type of infection. Large volume paracentesis with no albumin replacement, very important to always remember to replete albumin. And there's really not a magic number. In clinical practice in our center, even if the patient is having 2 liters of ascites removed, we start recommending to at least consider the addition of albumin. GI bleed, these patients will be, of course, at risk for GI bleed because of their esophageal varices. Acute alcohol hepatitis can also be a trigger for HRS, but more often than not, and very frustrating, a cause cannot be identified, and you just basically have to deal with the consequences of HRS even if the cause was not identified. Now let's talk about the diagnosis, how we're going to make the diagnosis of HRS. So you'll often hear people saying HRS is a diagnosis of exclusion, and that is true, because the problem is we don't really have a test that can tell you this patient have HRS. And we're gonna, hopefully we have the time, but the idea is that the research that we're doing will help us find a good biomarker that will help us identify these patients. So how do we do the diagnosis of HRS? So the diagnosis of HRS is essentially iterations at trying to find out if the patient doesn't have another form of AKI. So after you, and you'll see what I'm meaning by when I go through each of these steps. So the patient must have cirrhosis and ascites. So I told you there has to be portal hypertension for this disorder to appear. Then the patient will have AKI, and based on the criteria that you can find in the International Club of Ascites, it's essentially, you can divide it in different stages, but as long as you see a raise in creatinine greater than 0.3 from baseline, that patient has AKI by definition. Now, lack of improvement with albumin. So here's the first AKI that you're trying to rule out. You're trying to demonstrate that this patient doesn't have renal AKI. So if after a judicious volume challenge, this patient is not improving, more fluids not gonna work. If you already demonstrated that there is no improvement in the creatinine, at least 2 days with no diuretics, stop the fluids because this is not renal AKI. They also have, this is very challenging, this part, absence of shock. So remember that I told you that there is a splenic vasodilation and that the body is acting as if the systemic circulature is down, even though at the level of the renal vasculature is all constricted. So even though the MAP will be low, the mean arterial pressure, you need to make sure that this patient is actually not in septic shock. Because if that's the case, then probably the cause of the AKI in this setting will be acute tubular necrosis. And that's the other form of AKI that you're trying to rule out here. Then by the same token, you need to make sure that your patient hasn't been on known nephrotoxins. And nephrotoxins, you know, it can be many things. I want you to start thinking about chemotherapy agents because as you know, science is moving forward. There's been descriptions of AKI in patients taking tyrosine kinase inhibitors, checkpoint inhibitors, and that's a whole different ballpark because those patients more essentially will have acute tubal interstitial nephritis. So make sure to really do a really good assessment of the medications and that these patients are not on nephrotoxins. And then you'll have to rule out the big bulk of other diseases related to the kidney, that they don't have proteinuria, that there is no hematuria, and that they are not obstructed. After you've done all that, then you can probably say, okay, I think this patient has HRS. So you see how complicated it can be, and especially when you're on call at 8 p.m., your pager is going off, and then you get a patient in the middle of the night saying, you know, you have an admission AKI with cirrhosis. You do really need to go through this algorithm before you can call someone HRS. But if you have this in your mind, you'll have the opportunity to really nail the diagnosis, because a lot of people will actually be in this category. So you can really change the course of the disease by providing some fluid challenge and see the creatinine coming down. Now, patients with glomerular disease can also have HRS. And this makes the whole aspect of AKI and cirrhosis even more challenging. But that's going to be a discussion for another time. Now, we're going to move forward, and we're going to talk about the types of HRS very briefly. So we recognize two types, type 1 and type 2. And so type 1 is essentially rapid progressive renal failure, again, in the setting of the diagnostic criteria that we have discussed. They typically have been precipitated by some of the factors that I mentioned, most notably spontaneous bacterial peritonitis. And some researchers are trying to move away from the type 1 and type 2, and they're calling HRS AKI. On the other hand, you'll have a type 2 HRS, which is even more nuanced. So these patients can actually be in clinic. And these are the ones who you're going to be seeing coming again and again for large volume paracentesis. They'll have some degree of renal dysfunction, but not so severe. And it really follows a slow and steady course. Some researchers recognize as this entity as HRS CKD. These can appear spontaneously, and there's really not a lot of data, and is essentially poorly understood. But it's really important to recognize these two types because they die differently. Now, the prognosis of patients with HRS, this is the topic of a whole conversation. Why it's so important to discuss this? Because the only known treatment that is curative for these patients is a liver transplant. And allocation of liver transplant, as you know, is not available for everyone. So we use different scores to try to gauge which patients are going to receive a transplant versus not. And I told you already that this patient population are really, really sick. I don't need to convince you of that. You know that these patients are really in dire need of a liver transplant. But the prognosis of HRS is something that hasn't really been studied in the context of MELD and transplant allocation. So what I'm trying to show you in this graph is the relationship between MELD and the 3-month mortality of patients who are depending on the MELD score. What I'm trying to show you here, this is the general population, so patients who are with liver cirrhosis, liver dysfunction, but do not have AKI, and these are the two types of HRS. So you can see how type 1 HRS is really a deadly condition. So this is the survival at 3 months. So for a patient with an MELD score of 20, their survival is almost close to 80, 90% 3 months. But that same patient with the same MELD score, if they have type 1 HRS, their survival is really only about 20%, like 3 months. So many of these patients, even though they are sick enough to receive a transplant, sometimes they don't reach the time for allocation of the transplant because essentially they're just really sick to obtain. And also the MELD, even if the MELD is really low, the mortality is really high. So MELD is not capturing the mortality of this particular patient population. That's something I think will have a lot of implications in the allocation of transplant in the future, because what my group is trying to develop is a better way and a better tool that can show us how these patients can benefit from a liver transplant. And of course, there are many other forms of kidney disease in patients with HRS. IgA nephropathy is probably the most common type of glomerulonephritis that is associated with liver disease. But then you have a bunch of others: hepatitis C, hepatitis B, and some other more rare forms. And of course, the complement is going to be difficult because these levels are really low in the patients with cirrhosis. So this determination is going to come in conjunction with your colleagues from nephrology, because it's not easy to try to identify cause glomerulonephritis within the context of cirrhosis and AKI. And this is where the urinary sediment, which is a tool that we perform in an assessment, is going to be very important, because we may see RBC cast, and then our diagnosis can definitely change just based on that. Now, we're going to talk about the management, and I want to show you this slide because we often talk about how can we reverse HRS. Once a patient is in HRS, how can we make it go away? So this concept is really not new, and it's been present many decades ago. So I want to show you this particular study. Well, it's not a study, it's a case report. And see what they were trying to do at that time. This is 1984. They were trying to see if head-out water immersion was beneficial for hepatorenal syndrome. And I'm gonna tell you exactly what they did. So they had a 47-year-old female patient with what seemed to be HRS. They put the patient in a bathtub and connected a Swan's gun through this patient and cannulated peripheral arteries and veins. So what they were trying to see if water immersion was able to move the circulation and improve the vasculature derangement that these patients had. And here, as you can see, they were measuring a bunch of parameters: hemoglobin, hematocrit, plasma protein concentrations. Anyways, I'll reserve you the details, but unfortunately, the patient's renal function progressively deteriorated over the next 15 days of water immersion. But tubular function was relatively intact during the days after the study. So they concluded after this seemingly heroic or strange intervention that a considerable increase in effective blood volume did not restore renal function in HRS. So they were thinking that a potential hypothesis was that therefore the proposed reversal of HRS needed volume expansion. They were already advocating for decompression of abdominal pressures. This was the time when albumin was not recognized as a therapy for HRS. People were really desperate trying to find solutions to this problem. Now we're not on those days anymore, and therefore we have treatment algorithms that help us guide us with the management of these patients. So what's the management? So there's gonna be what I call general measures, and then there's gonna be what I call the 4 major therapeutic interventions. So general measures: hospitalization for HRS type 1, CVP assessment. You need to hold diuretics because this is part of the trying to rule out if this is perirenal. Yes, you'll see that these patients are overloaded. Yes, you'll see that they have lower extremity edema. They will have ascites, but remember, that fluid is not in the vascular space. That fluid is sequestered somewhere else. So diuretics are not going to reach them. If these patients have ascites, they probably require paracentesis and most likely with albumin repletion. And other measure is it's going to be a low salt diet and frequent restriction. But really, where the magic is in the 4 major therapeutic interventions. So medications such as vasopressors, hemodialysis for patients who have indications for hemodialysis, TIPS, which is the transjugular intrahepatic portosystemic shunt, and liver transplant. So I'm going to discuss a few of this in some level of detail. So as internists, this is what we do: pharmacologic treatment of HRS. So very well recognized the role of midodrine and octreotide. But we have other tools at our disposal. So not approved in the US, vasopressin analogs, terlipressin is also a vasoconstrictor that is thought to have some degree of splanchnic vasculature selectivity. The somatostatin analog octreotide and the alpha adrenergic agonists such as midodrine and epinephrine. But you'll be surprised. So even though we use these interventions, the number of randomized controlled trials testing them are really not that many. So there is only 1 trial testing midodrine and octreotide, and the reversal of HRS was really not that high. And there's even a big number of randomized controlled trials testing norepinephrine. However, terlipressin is probably the most well-studied drug for this particular setting. Now, why don't we have it here in the United States? Our colleagues from Europe are really way ahead of us with better rates of HRS reversal, and they have approved terlipressin for the management of HRS. Now, there are a few caveats, and this is what I want to get into. So midodrine and octreotide, the rate of success is really not that high, but this can be given in the medical ward. So you don't need to admit these patients into the ICU in order to start midodrine and octreotide. And they're relatively cheap compared to the other medications available. The big con is essentially they don't work as well. And you'll see that we occasionally just ramp up the doses of these drugs, but really they're not as effective as other medications. Now, vasopressin and terlipressin. So terlipressin is the best well-studied. So 50% effective at reversal of HRS. It has a few cons because it's such a potent vasoconstrictor, it can cause ischemia. Vasopressin will do it more than terlipressin. And there has been more respiratory events in the terlipressin groups, but the rate of correction is probably the best of all the other agents. And what is a standard of care here in the United States is the use of norepinephrine, but the con is essentially you need to put this patient in the ICU so you can essentially start norepinephrine, because this medication cannot be given in the floor. And you know how many resources are required to put a patient into the ICU. So therefore, that tells you how sick this patient population is. Now, what's the deal with terlipressin? So the deal with terlipressin in the United States has been that the FDA hasn't really approved this medication despite a number of clinical trials. However, the confirmed trial was just published in the New England Journal of Medicine. This was a randomized controlled trial, placebo versus terlipressin, paid by the pharmaceutical company. And as you can see here are the demographics. Some of the patients, all of the patients were type 1 HRS with a creatinine of 2.2, and the primary endpoint that they were trying to test was what they call verified HRS reversal. So what does that mean? So it means two values of serum creatinine less than 1.5, 2 hours apart. And alive, that was one of the other secondary endpoints, that the patients were alive without dialysis for at least 10 days. And here are some of the demographics of the patients, and you see a great deal of them already failing midodrine, octreotide, and albumin. So these are probably the sickest of the sickest that you can put into the trial. But interestingly, terlipressin achieved almost 30% reversal of HRS compared to 15% placebo plus standard of care. Now, this data suggested that terlipressin was able to achieve better rates of reversal of HRS, but what was the problem? The problem was this, that a secondary analysis of serious adverse events led to the understanding that terlipressin was associated with respiratory failure. So patients in the terlipressin group were more likely to have respiratory failure requiring intubation, and sometimes that would lead to death, which possibly led to the inability of the drug to achieve the secondary endpoint, which was that the patients need to be alive and off dialysis. So even though terlipressin did improve kidney function in these patients, it did not improve survival, essentially because of respiratory failure. Now, you need to start thinking, so why is Europe using it? Why do they achieve better reversals of HRS? And so why is all this? And this is just to show you some of the press release. Essentially this came out last year, FDA rejecting terlipressin for HRS type 1, and their concern was that it was not associated with improved survival compared with placebo. And the committee was really concerned about the respiratory failure events. So what happens, what is terlipressin doing? So terlipressin, again, is a selective splanchnic vasoconstrictor. So this is where it's gonna try to attack the fibrosis of the liver, the pooling of blood in the abdominal compartment. But remember, these patients, they are not getting only terlipressin and vasopressors. 60% of the patients that were in the study already received octreotide and albumin. So here is where I think the key of the matter is. So albumin is a molecule that has shown some benefit on HRS, but the primary mechanism of action of albumin, what it is, it remains in the intravascular space. Now, the idea is that to increase the oncotic pressure on this particular patient. So think about it. If you are already loaded with albumin, if your oncotic pressure is already out, what will happen if you suddenly pull all that fluid from the abdominal compartment back into the systemic circulation? Guess what's going to happen? Pulmonary edema. And possibly this is why the association between terlipressin and respiratory events came about. What I think happening here is that the patient population that they selected was too sick to benefit from this drug. And therefore, the idea should be that terlipressin must be used at a certain range. There'll be a moment in which even the best study vasopressor will not be beneficial for HRS. But, and this is where I think our colleagues from Europe are winning, because they are maybe selecting the patient population that probably will benefit from terlipressin and probably hasn't really been loaded with AB albumin that will essentially lead to this circulatory overload that we very often see in these patients. Now, leaving the medications behind, so there's another intervention called TIPS. So this is the transjugular intrahepatic portosystemic shunt. This is not approved for HRS. This is only in the context of research and patient selection. But what is the mechanism of action of TIPS? So TIPS reduces portal venous pressure because you're essentially bypassing the liver, connecting the systemic circulation to the portal circulation. It increases central valve volume, is very useful in patients with refractory ascites. There's data that may suggest that even may be superior to LVP, but there are complications that can exist. There's a significant amount of contrast that is used when you're placing the tips under fluoroscopic guidance, and the association between contrast and AKI is also a whole topic of conversation, but I tell you, non-nephrologists will be very comfortable loading contrast on a patient who's really sick. There's also the potential for exacerbation of hepatic encephalopathy. Why? Because you're bypassing the liver. So whatever parenchyma that is still viable is doing to clear ammonia. When you put a TIPS, you essentially bypass the ability of the liver to clear ammonia. So you can trigger crisis of hepatic encephalopathy. And of course, with any procedure, these patients are already coagulopathy. They have thrombocytopenia, and there's a really high risk of massive bleeding when you're perforating the liver. And this is what really happens. So essentially, you're bypassing the liver and bringing all that systemic circulation back to the heart. And with increase of the cardiac index and potentially increase in the vascular perfusion of the kidneys. So this is how it's performed. These are pictures that were courtesy of a good friend of us who's an interventional radiologist. So essentially you puncture the IVC through the neck, going into the hepatic vein, and then you create a tract in which you will cannulate the portal circulation, and then a stent will be deployed. So he is already, the stent is already placed here, and it's already bypassing the liver. So all this blood from the portal circulation will immediately go directly to the systemic circulation. And this is a case of a patient who had a TIPS placed around this time. So this is the serum creatinine already going into the tubes. And as soon as the TIPS was placed, her creatinine over time really improved. Her sodium as well increased from 124 to 141, but she's maintained in lactulose permanently, because otherwise, as I said before, hepatic encephalopathy crisis might ensue after you place the TIPS. But again, this is not standard of care. These are really selected patients. There may be some signal of benefit, but it's not devoid of risks. And it has to be done in an expert center that is dealing with these particular issues. But the elephant in the room, what about dialysis? So what about dialysis? So, and this is gonna be more often than not, the role of the nephrologist is very important at leading very difficult conversations, because what happens? So in our series, out of every patient who has HRS, who meets criteria for dialysis, at 6 months, only 10% of them are alive and on dialysis. So there's this concept that these patients are so sick, they have such a poor vascular reserve that they will be unable to sustain the demands of 3 times a week dialysis. In fact, sometimes we said to the primary teams, you may think that by requesting dialysis, you're asking us to help this patient. But in fact, what very often happens is that we shorten the lifespan. But this is a whole topic of conversation as well. So what are we doing now? So we're thinking on the following. So let's think of dialysis not as an end, but as a bridge. So dialysis is not going to be the cure. The cure is a liver transplant. So can dialysis extend the lifespan of this person long enough for them to achieve sobriety, to get better and receive a liver transplant? That's where we collaborate with our colleagues from hepatology, and we often do not request expedited inpatient transplant evals. And after they make their assessment, we select carefully our patient population, and some of these patients we do offer renal replacement therapy. So the way we like to think about dialysis is, if a patient is already listed for transplant, then definitely we can think as dialysis as a bridge to transplantation. The patient who is not listed but a potential candidate, we initiate expedited transplant workup, and then as well we initiate renal replacement therapy. However, those patients who have a contraindication to transplant, being that they are not sick enough, or that they haven't achieved sobriety, if they're continuing drinking, then this is where things get even more complicated, because you already know that if you put this patient on dialysis at 6 months, their chance of mortality is essentially 80 to 90%. So very honest cost of care discussion help with the palliative care services. And then you start asking these questions, is there any chance of reversibility? Is this patient a future? Maybe the patient is not a candidate right now, but is there a possibility for this patient to be a future candidate for a liver? Would they tolerate dialysis, or would they need ICU level of care to start CVVH? Then there might be a selected number of patients, because even though 80 to 90% will die at 6 months if you put them on dialysis, maybe that 10% are those patients who probably might be candidates for what we call a limited trial of IRT. So limited trial of dialysis means we start dialysis, we see how you do clinically, and then we reassess. But more often than not, cases will focus on comfort and end-of-life care. And very complicated conversations, because typically these patients come with their 5 senses. They might have AKI, they might have liver cirrhosis, but they're still up and about. They probably had a paracentesis that went south, and then now they develop HRS. And then they might not be that old. They might have families, kids, and then you start talking about these issues about end-of-life care. So just leave that part of there, because we can continue talking the whole day about the issue of dialysis in liver cirrhosis. But what are we doing in our center? So we develop an algorithm that helps us guide us care, and this is what we give to the residents, so they can have an algorithm when they admit these patients during the night. So essentially, any patients with AKI and cirrhosis, you do an early diagnostic assessment with urine sodium, check the sediment if you can, order a renal ultrasound. Maybe you can rule out obstruction. Maybe you'll find, a polycystic kidney disease, remove the risk factors, and start a volume expansion. And after 2 days of the initial treatment, if your patient improves, then most likely this was perirenal, most likely this is reversible, and essentially you're off the woods. However, if the patient doesn't improve with the initial interventions, then you start thinking, is this patient meeting criteria for HRS? If they don't meet criteria for HRS, then you have to, call your colleagues from nephrology, try to discuss if there's any possibility that there is a glomerulonephritis or any other form of AKI. But because this talk is about HRS, so we're going to assume that this patient has HRS, immediately you need to start a multidisciplinary approach and discuss or check the chart if this patient has been already evaluated by liver for a potential transplant eval. And if not, you won't be wrong initiating these conversations really early on and start treatment, what we call MAP guided treatment. So I'll show you what the algorithm looks like. So you titrate midodrine and octreotide to a MAP. So you calculate patients' baseline mean arterial blood pressure, and you titrate these vasopressors to response. And if after 24 hours of maximum midodrine and octreotide, the MAP does not improve, you have to start thinking on this route, discuss ICU, discuss, is this patient a potential liver candidate or not? These are where the conversations get really, really complicated. And consider initiation of vasopressors. You might be surprised, maybe you'll be able to put this patient into the category that increases MAP response with potential reversal of HRS. But if that's the case, if things go into the route of resolution, you continue treatment for 24 hours. And then in centers where experienced, you discuss the potential for a TIPS on these particular patients. We are trying to modify this algorithm right now. And I'll explain why at the end of the talk, but this is right now what our standard of care is in the medical floors. So finally, if we have some time, I would like to make a plug of all the exciting things that we're doing in terms of research. So the role of biomarkers is something that I feel very attracted to, because the potential of biomarkers is that these are molecules that should be elevated or they can be detected in certain disease conditions. So the first one that we studied is called angiopoietin-2. And we found that angiopoietin-2 can predict mortality in patients with AKI and cirrhosis. So what is angiopoietin-2? So this is a molecule that is part of a family of what we call vascular growth factors. So essentially, this is an axis in which angiopoietin-2 and TI2 interact together. So TI2, these are receptors that are diffusely located at the level of the endothelial cells and promote addition of the endothelial cells. Angiopoietin-2 is an antagonist of this interaction, and therefore it'll promote detachment of the tight junctions of the endothelial vessels. And it was found that this molecule was elevated in patients with liver dysfunction, especially those who have splenic vasodilation. So we were really interested in learning, can we, can this be our marker for HRS? What we found out was that those patients who had, among those patients who were candidates for liver transplant, so the higher their angiopoietin-2 level was before, we saw a dramatic decrease after a liver transplantation 30 days after their initial admission. So the highest the angiopoietin-2 level was, after liver transplant, we saw a dramatic decrease. So this was telling us something already, that this marker was most related to the dysfunction of the liver. So if you put back a liver that functions well, most likely this protein gets cleared by the system. And we compared that to patients who never received a liver transplant and who unfortunately died after 30 days. So as day 0, you have a level of angiopoietin-2, but as their disease progressed and they were unable to get a liver transplant, you see the level of these molecules elevate. But what was the problem? The problem was that it did not help us determine or differentiate the cause of AKI. So there was not statistically a difference between the 3 forms of AKI. Yes, it was associated with patients who had need for renal replacement therapy. Yes, it was more elevated in patients who had more severe form of AKI, but it did not help us differentiate between the forms of acute kidney injury. So we cannot use it as a marker to help us diagnose HRS versus ATM versus perirenal. But it was nicely correlated with mortality. And we think that this is a marker most representing liver health integrity rather than kidney. But we were not discouraged by this and therefore enter NGAL. So NGAL is another molecule that is now being investigated by several groups. So everybody will tell you from the nephrology world that creatinine, even though it's important in the definition of AKI and cirrhosis, is really not a great marker. Why? Because liver cirrhosis patients are often muscle wasted. They don't produce enough, a lot of creatinine compared to patients who have preserved muscle mass. So so this is where we start thinking. So we really need to come up with a marker that can show us that the kidney is having some degree of damage. So why not albumin? So albumin, the problem is when you detect albuminuria, the problem is the glomerulus. But here in HRS, the glomerulus is preserved. The problem are the tubules. So this is where the search for a tubular marker of kidney damage came up. So NGAL is a protein that is secreted by proximal tubular cells after they have received some degree of damage. Now, the problem is, can we differentiate from HRS and HEN? Because the management of the two is very difficult, and essentially people need to make the diagnosis based on clinical grounds. So this tubular marker is called neutrophil gelatinase associated lipocalin. This one demonstrated to have the best performance amongst a bunch of other proteins that were studied. But again, Europe has more data than us, but we were proud to come up with one of the largest cohort in America for the study of NGAL. So NGAL was able to discriminate non-ATN AKI. So what do I mean by this? So the patients who had the lowest tertile of NGAL were those who had perirenal AKI. Higher levels were HRS, and highest levels were ATN. So this was really important because the highest the level of NGAL, that means that there has been such a degree of tubular damage that these patients most likely have ATN. So for the first time, we were able to finally try to discriminate different forms of AKI. And it had a really nice negative predictive value of 86% for the discrimination of ATN. So if your patient had elevated NGAL and did not respond to fluids, then you really can nail the diagnosis of HRS in this particular context. This is another graph that demonstrates how levels of NGAL really correlate with survival. So those with the highest levels of this protein were also the ones who die more often. And this is where we want to provide some, this is where we want to make a dent in the world. We really want to change the way transplants are allocated in patients with HRS. I show you already that MELT does not capture the severity of HRS and doesn't capture the mortality. But when you add NGAL to the MELD score and you divide this by tertiles, you definitely see a dose response in the level of mortality. So our proposal here has been to try to add NGAL to the MELD score in order to improve mortality correlation and hopefully better allocate transplant to these patients. So in summary, we can say that AKI in cirrhosis is associated with high mortality regardless of the cause. So I hope you can bring this point home that it doesn't matter if this patient has renal, ATN, or HRS, mortality can be really, really high in this patient population. HRS is largely a hemodynamic insult and warrants vasoconstrictor and albumin therapy. And hopefully I can make you feel excited that new testing and therapies are coming. So one of the therapies and testing at the same time that we're looking into is the role of POCUS. So how can we tell if these patients are going to benefit from albumin versus not? So we are developing an algorithm, and this is all experimental data that we haven't studied yet, but we're writing the protocol. So we plan on scanning these patients using handheld ultrasound devices and see if we can come up with some indices that tells us how full they are from the intravascular space. And what we're planning on doing is seeing those patients who are already intravascular full, and maybe those are the ones who maybe benefit from diuretics versus the other subset of patients that are vascularly depleted, who may warrant albumin trial, but as soon as they don't improve, move directly to vasopressors. This is still in the works, and hopefully there'll be a time in which this data is published, and then we'll be really happy to present. But I think my time might be done.
Thank you, Xavier. Your time is never done, and you're always welcome to present any new findings. This has been incredibly interesting. I know that there are a few questions in the chat, if that's okay. Yes. I mean, you can, one of them I know you already answered. I think Mantage was probably referring to the comparison between the NAFLD and the MELD versus MELD sodium score and survival rates.
Yeah, MELD and MELD sodium score do not capture the severity of the mortality in HRS, unfortunately. I did not show the data, but the curves are essentially very similar when you compare MELD versus MELD sodium. So it may improve when we also add NGAL to the MELD sodium score, but I don't have the data yet.
And then I guess this is more of a logistic question, whether you do vasopressin there with an ICU admission, or does it require that level of care like it would with other vasopressors?
Yeah, so
titratable dose.
Yeah, vasopressin in our center is not titratable, so there are fixed doses. What we are trying to titrate is we titrate to MAP, and because titration is really important, we really prefer doing norepinephrine because you can really tweak the dosage really easily. But unfortunately, vasopressin doesn't really titrate as well as norepinephrine. And when we go to really high doses of vasopressin, we start seeing finger ischemia, necrosis. So we know that those patients are really not going to do really well.
I hope that answers your question, Chris. And then Francisco is asking if you find any other role to other renal biomarkers such as cystatin C.
Absolutely. So cystatin C. So cystatin C is created by every nucleated cell in our body and is freely filtered by the glomerulus and is excreted completely in the urine. So a fantastic marker. Now, this is a marker of kidney function, analogous to creatinine. It is better at finding AKI in patients with cirrhosis because, again, creatinine comes from the muscle. Patients with cirrhosis really don't have muscle mass. So in that setting, cystatin C really performs much better compared to creatinine. Unfortunately, it doesn't discriminate, again, the cause of AKI. So every patient with a perirenal AKI will have an elevated cystatin C, and the same will happen with those with HCN, glomerulonephritis, or HRS. But really, really good point. That's another really good marker but it's a marker of kidney function. It really doesn't inform us of the integrity of the tubules.
I have one question. Thank you so much for that. I know that when you were going over the criteria to diagnose HRS, you said there needs to be absence of shock. So is that only septic shock, or if someone has a GI bleed and has hypovolemic shock, can you then make a diagnosis of HRS, or then would you attribute that to the hypovolemia shock?
Yeah, important question. And that's the point of contention between intensivists and nephrologists when we see these patients. What does shock mean? So shock is essentially vascular collapse that it doesn't meet the demands of the body. And shock can have different forms. So it definitely can be septic shock, but very often than not, we see the common scenario, GI bleed leading to hemodynamic hypovolemic shock. So after you haven't treated the cause of the shock, you cannot call a patient HRS until you have addressed that elephant in the room. So you gotta address the septic shock, the cardiogenic shock, any type of shock. But it becomes really difficult because I already told you these patients come with really vascularly open at the level of the splenic circulation. So far in clinical practice, what I found the most helpful is I typically go back to the chart if there's more data, and I look at the trend of the blood pressure of these patients. If they have been having very robust blood pressure before this clinical presentation, most likely something acute happened that may be able to correct, and I start looking then for the septic shock, for the bleeding, for the cardiogenic shock. In the contrary case, maybe this patient had HRS type 2, and these are the patients who tend to run low, like 90s over 60. They go to clinic and the blood pressure is 86 over 40, but they feel well. That's probably an HRS hiding there. But yeah, you need to address the shock first before you can call someone HRS. But that doesn't mean you cannot say, well, this patient, even though it's in shock, may have HRS. It's very difficult.
Thank you.
Thank you, Javier.
That's
I
a
just
known
have
voice.
a question.
I know that
It's me, it's Yaras. How are you?
voice. Good to see you.
I have a question. Good to see you too. So what are the predictors of like renal function reversibility after liver transplantation? And what are the situations, I'm not aware if there are any, that patients need like combined renal and liver transplantation? Yeah,
absolutely. So very important question. So predictors of renal, let's call it renal success after liver transplant. So increasing cardiac output, that has been associated with improved kidney function after liver transplantation. Improvement in the cardiac index, which go hand in hand with the cardiac output. And surprisingly, decrease in bilirubin has been strongly associated with chances of success after a liver transplantation. Those are probably the most strongest factor associated. So if your patient gets a liver transplant, they improve the cardiac contractility, bilirubin comes down, chances are that they are going to do relatively well after the transplantation. Now, the issue of combined liver and kidney is a public health problem. As nephrologists, we have made as easy as possible for patients to get a kidney because our criteria are not that strict. So if a patient has a eGFR that is less than 30 over the span of 6 weeks, immediately can be listed for a kidney transplant, regardless of the cause. So we don't care about the cause, as long as they have been having creatinine at that level, or that you have been on dialysis for the same period of time, for any AKI. It doesn't matter the level of the creatinine, and it doesn't matter the cause of the AKI. So clearly the issue is going to come to whether or not they can receive a liver or not. But we can make these patients eligible for kidney transplant really quick. I didn't add it. Yeah, no worries. I didn't add that data just because of respect to the time, but that there's a whole discussion regarding, combined liver and kidney transplant.
We'll call you back for you to share all that data that's missing. We'll give you more time. Thank you again. I hope you all had, those questions were very interesting. Thank you everyone for participating. And Xavier, have a wonderful rest of your day.
Thank you so much. It was a great honor. It was really fun to talk to you guys, and I'm really proud of all you guys. You're gonna make great things. I'm really sure.
I'm sure.